My connection with addiction started with my career in healthcare. Through medical school, residency, training, and now 20 years of practice in clinical emergency medicine, I've encountered patients from birth to death challenged by opiate dependence and addiction. This isn't a disease just of the homeless and derelicts. With alarming increased frequency, I provide direct patient care to members of the Valley View community, childhood playmates, their parents, their children, my friends. I provide care in 7 local emergency departments, and not a single day passes without encountering patients in some form of struggle with their opiate addiction. Some of these journeys started with the prescription pad of a well-meaning physician trying to meet the needs and expectations of their patients. Others started with harmless experimentation of nicotine and marijuana as a teenager or a young adult, escalating as their brains morphed with each new experience to create a disease that altered the structure and function of their brain. Many of these younger people never even touched the medical system. Regardless of the origin, the result is a pathologic need for continuous opiate exposure that creates fear, anxiety, desperation, and anger. Patients turn to the emergency department for many reasons. Most frequently, I care for patients with complaints of pain in hopes of obtaining a prescription for additional narcotics. They exaggerate symptoms or have minor injuries and demand narcotics that aren't indicated. They burn bridges with primary care doctors and have nowhere to turn to curb their narcotic needs. For those that have turned to IV opiates such as heroin, I see more serious complications such as skin infections, heart infections, and infections of the brain and spinal cord from bacteria traveling through their bloodstream. Others contract more devastating infections such as hepatitis or even HIV. The extreme I care for are patients who stop breathing as a side effect of opiates leading to cardiac arrest. Paramedics, police, and even family members often heroically save lives prior to the patient getting to the emergency department by administering naloxone or Narcan, a medication that blocks the opiate and reverses the effect. Some patients require life support because the injury to their body and brain is severe. Unfortunately, too many times, I have to tell family that our efforts at resuscitation were not successful and the person they loved, the person they gave birth to, raised, or married, or befriended, did not survive this powerful addiction. I try to help patients and families understand that addiction is a chronic, relapsing brain disease characterized by compulsive drug seeking and drug use, despite the complications, creating behaviors that are irrational and self-destructive. According to the National Institute of Health, brain imaging studies of patients addicted to drugs have shown physical changes to the areas of the brain crucial to judgment, decision-making, learning, memory, and behavior control. Researchers feel these changes alter the way the brain works and may explain the compulsive need for drugs and the destructive behaviors of the addicted person that aren't easily modified with the love and support of friends and family or the compassion of the healthcare system. I think this explains why even with the strongest of support systems, there are still treatment failures, and our loved ones succumb to these powerful disorders. I want people to know that there's a renewed call to action for healthcare providers. Just weeks ago, Dr. Stephen Stack, the current president of the American Medical Association, sent an open letter to all physicians to end this epidemic. He urges physicians to avoid initiating narcotics for new patients with non-cancer related diagnoses. He asks us to give very limited doses of opiates just after surgery or injury. He reminds physicians that we must work to reduce opioid exposure for those already on chronic treatment. Dr. Stack is encouraging the consideration of prescriptions for Narcan in these patients at high risk for overdose. Locally, we refer patients to community resources to assist them and their family with counseling, Narcan education, and even free doses for family members. There are new Suboxone and methadone treatment programs. Vivitrol, a newer medication used as a monthly injection to block the effects of opioids, still has limited availability when not part of the penal system, but we are seeing expanded conversations in the availability of this resource. Additionally, there are needle exchange programs in Dayton open to any user to help curb the transmission of disease. The message I want to deliver is that addiction doesn't have to be hopeless. Research shows that combining behavioral therapy with medications where available is the best way to ensure success. However, we have a lot to do. We have to start with honest conversations, such as the dialogue created by the Valley View Coalition. We have to open our eyes and recognize in our friends and our family members the physical and behavioral signs of addiction and encourage the road to recovery. We have to remove the stigma associated with drug abuse to enable compassionate care. We have to expand local resources for those committed to recovery that is tailored to each person's drug use, their pattern, and their drug-related medical, psychiatric, and social problems. These conversations haven't come fast enough for the mothers and fathers and brothers and sisters and family and friends of those that have lost their life to addiction. We have to continue to talk about those lives. We have to use their memory as beacons of hope for what has to happen next. My name is Tom Proctor, and I care.